at 7 o'clock. I take over from the night person. I carry a phone, and in my hospital there are two anesthesiologists on labor and delivery at all time. So since I'm there every day, so I'm either the floor anesthesiologist who does epidural, or the C-section person who does spinal anesthesia and stay in the OR. So I alternate between those two roles every day. And then 4 o'clock, 5 o'clock, I leave home. I leave to go home.
Okay. So you said you were on the floor. You said the floor anesthesiologist. Mm-hmm. What does that mean?
Yeah. So it means that it's a labor floor. So labor floor means there are different rooms. There are like several rooms where labor patients are in, and if they're in pain, they would call me.
Welcome back, YouTube. I know you guys were asking for an anesthesiologist, so guess what? I got you one. Today, Dr. Clarke is going to join us, and we're going to discuss her journey and what she does as an anesthesiologist. She has some really cool stories and some great lessons, so stay tuned. Welcome, Dr. Clarke. Thank you for being here. Can you introduce yourself, please?
Sure. I'm Dr. Clarke. I'm the attending anesthesiologist. I am working at Hackensack University Medical Center in New Jersey, and I do mainly obstetrics. So I'm essentially an obstetric anesthesiologist. I train residents, and I teach them, and we also have medical students rotating through our program as well.
Okay, so what's obstetrics?
So basically, labor and delivery. So I do neuraxial anesthesia mainly, but obviously occasionally I do put patients to sleep, but I shouldn't say sleep really, because sleep is a natural state. What we do is not really natural, but I put the patient under general anesthesia when need to, but those patients we tend to keep them awake. So neuraxial anesthesia is what I perform.
Oh, okay. So how does working with the residents differ from doctors who are working in the hospitals or in their own private clinic?
Okay, so essentially, you get to teach. I feel like they keep me on my toes. They keep me up to date, and you sort of like forced to read because you need to teach them. And I mean, I like to teach. I like to, people usually go into anesthesia because they don't like to talk that much. I mean, personally, that's why I chose anesthesia. I don't like to talk too much to the patients or other people. But I find teaching residents fun. So, and they are our future, right? They are going to represent our field. So I want them to see a good role model so they can become a good anesthesiologist in the future.
Yeah. So can you tell us about your background and how you got into anesthesiology?
Yeah, sure. So I was born in Thailand. I grew up in Thailand part of my life, and then I came to America when I was 14. I'm 39 now. So I came here when I was 14, here meaning New York, really, Queens, New York. So I grew up in New York, went to high school there, and then college also in New York. Went to med school. I didn't do the whole straight path of like, back to back to back. I took breaks in between because I was an immigrant, so I had to work full time and also supported myself and my family back home. So then I did research for maybe a few years, medical school, then a residency, and then an attending job.
Oh wow! So what would you say is your favorite part about your job?
Oh wow. There are many things. I like doing procedures. Clearly, I like to be walking around more than sitting, monitor while the patient is under general anesthesia. So on labor and delivery, you do Nuraxo, and essentially it's epidural and spinal anesthesia. So you block pain for labor epidural, for labor analgesia, and for C-section, cesarean section, we do spinal anesthesia. Only when there is an emergency, we put the patient to sleep. So I like the procedural part of my job a lot. And this place allows me to teach residents, not only during their rotation on OB, but also I teach lectures. So those are the two good things about my job as well. I like, I guess, the fact that my patients are awake, but it's not like the whole, like it's a brief interaction. It's not like a long interaction.
Yeah.
I like that aspect of anesthesia as well.
Okay, so I just had a question about why wouldn't you put the patient to sleep when they're in labor?
Oh, not when in labor, but when there is an emergency. For example, patient who are in labor and, when the baby's not doing well, for example, when the baby's heart rate drop, that shows that baby's actually hypoxic, meaning the baby's not getting oxygen. You need to get the baby. So if the patient doesn't have an epidural, or, you go so fast that the epidural doesn't work fast enough, then you need to put the patient to sleep, because you need to get the baby out now.
Okay. So your part in this whole procedure is just putting the patient to sleep, or do you do something else as well?
So the main part on labor and delivery is epidural analgesia, which is putting an epidural for labor pain. For C-section, we do spinal anesthesia, where you put the medication through the spine, and essentially they have sensory block for the entire procedure. And for patients who are for emergency C-section, and if we can't do a procedure on them, then we put the patient to sleep.
Oh, okay. All right. So how about let's go through your workday. Can you tell us about how your normal workday looks like, and like how many days of the week you work, and how your workload looks like as well?
Oh yeah, sure. Okay, so traditionally, anesthesia comes with calls, right? And calls mean you stay in the hospital, in the call room. When there is a case, you go do the case. So that's traditional anesthesiology. It's our field, because if you're home, you can't run fast enough to save the patient's life, right? However, with everything that's changing, I personally don't take calls. So I work Monday to Friday from 7 a.m. to 4 p.m. However, if I would want to take calls because I have nothing to do on the weekends or like at night, I can tell them that I want to be on call today, for example. But normally, if you are a traditional anesthesiologist who take call, you'll be working all day and then also all night, and you get the next day off. But for me, go in at 7 o'clock, I take over from the night person. I carry a phone, and in my hospital, there are 2 anesthesiologists on labor and delivery at all times. So since I'm there every day, so I'm either the floor anesthesiologist who does epidural, or the C-section person who does spinal anesthesia and stay in the OR. So I alternate between those 2 roles every day. And then 4 o'clock, 5 o'clock, I leave home. I leave to go home.
Okay. So you said you were on the floor. You said the floor anesthesiologist. What does that mean?
Yeah. So it means that it's a labor floor. So labor floor means there are different rooms. There are like several rooms where labor patients are in. And if they're in pain, they would call me to do an epidural on them for pain control.
Okay. So you just sit in. You also wait in the call room as well while during your shift, or do you?
Correct.
Yeah. Oh,
So
okay.
yeah, so I mainly stay, that's like my office. So I stay in my
Okay.
office, and
Okay.
when the patient requests for an
Mm.
epidural, I go do an epidural. Or
Oh.
if the C-section attending,
Mm.
then every day there is a schedule that is booked for the day. So let's say there are 4 sections today, starting from 7:30. Next one is 9:30. Next one is 11:30. Then I would go on to all 4 C-sections. After
Oh.
that's done, then I
Okay.
just wait to see if my colleague needs any help.
Okay. Okay. So how long does one procedure take?
I It depends on the anesthesiologist, but I do so much that I'm very quick.
Oh, okay.
So I mean, people would, the nurse sometimes times me. My record is 45 seconds when I do an
45.
epidural.
Wow.
So I mean, I go in and out very quickly, from one room to the next.
Oh, okay. In the procedure, like, what exactly are you doing? Can you describe that?
Yeah, so an epidural is essentially putting a catheter, a small catheter, into the epidural space. And this catheter is then connected to the pump where it infuses medication to help block pain, right? So the procedure we perform is that, we go to the patient's back, we clean the back really well because we don't want any infection that stays in the back and travels to the brain. And then we pick a landmark where we're gonna enter from the skin, and we
Okay.
enter the skin with an 18 gauge needle, which is a pretty big needle. So
Oh,
we numb the skin first because nerves live on the skin. So we
yeah.
numb the skin with a small needle and local anesthetics that block the
Yeah.
sensation.
Yeah.
Then you go in with a very big needle, and you get into the epidural space. Then you thread the catheter stays in the epidural space. And again, the catheter is connected to the pump where it delivers. And I program the pump such that the patient will never overdose on the drug.
Oh, okay.
And that's how the local anesthetics from the pump will block those spinal nerves.
Yeah.
So then they don't feel any pain.
So the pump, what do you mean by you coded it to not ever overdose?
So essentially, the pump, you can set your dose, the dosage of the drug. So essentially, you tell the pump, okay, give this much per hour.
Oh,
Patient
okay.
allowed to press for themselves, but this much um, of the drug, and how
Mhm.
often can they press.
Oh, okay.
So I set all that for that particular patient.
Oh, so it differs from patient to patient?
No, I actually have a pretty like a standard dose that I use for all patients. The difference is depends on how much they need initially, based on one, how much pain they have, and two, what's their cervical exam is like. So then that's how I determine how much I want to load
Oh,
initially, and then
okay.
let the pump run.
So what's the cervical exam?
So cervical exam is essentially when the obstetrician put their hand into the vagina and to check how much the cervix is dilated. So the cervix usually is closed,
Yeah.
right? Now when the baby is, when they are in labor, the cervix start to dilate, and it should dilate all the way to 10 centimeter before they can start pushing that baby out. So the
Oh, okay.
cervical exam is when they put their hand in there to examine how many centimeter is she. Also, it determines how thin the cervix is, and the
Oh,
last thing it determines is where is the baby in relation to pelvis.
oh, okay.
So based on that, and based on that, I can gauge how much drug I want to give
Oh,
to the patient initially, so then they can be comfortable fast.
oh, okay. That's okay. That's
Mhm.
okay. So how about let's move to your journey and how you became an anesthesiologist. So can you start off with like how long does it take to be an anesthesiologist, starting from like college and then going up?
Okay, so typically it takes about 12 years. So
Oh,
4 years of undergrad, whatever you want to major in, doesn't have to be science, but obviously you need to do your prerequisites, which is 1 year of biology, 1 year of chemistry, 1 year of physics, and I don't know if different school has different prerequisites, but that's like a typical prerequisites that you have to do. And I think 1 year of calculus to to fulfill the requirements to enter med school. Then you do 4 years of med school. After 4 years of med school, you choose 4 year your specialty, which is anesthesiology, and you do 4 years of residency. So total of 12 years.
12 years. Okay. And how is that, how is like school life, how stressful is it, do you think? Do you know how stressful it is compared to other
Specialty.
specialties? Yeah.
I guess it depends on what you like, because all residency suck, to be honest. Because many hours of work, lots of work, no sleep. Well, I shouldn't say no sleep, that's too much, too extreme, but very little sleep, a lot of
Yeah.
work, for it's like a cheap labor almost. And you still need to learn in the hospital, also need to read, right? So America in general, the system that we design residency is a lot of work in residency. So I don't think I can say like, oh, that specialty has less stress, and this specialty has more stress. It's just a matter of how each person perceives that residency. But obviously, you go into a residency knowing you like the field. So I think it's really hard to compare, because I would say, oh my God, surgery residency is so brutal. To me, it seems very brutal. Like they're up all the time, they stand all day, they never go home, they get whipped and talked down to by surgeons. To me, when I see it, I'm like, oh my God, your training is brutal. My training compared to them, to me, is like nice, you know? So like it's hard to compare, I feel like. But all residencies suck, right? So in general.
So for students who are going through residency right now, or for students like me who will be going through the residency in the future, what advice do you have for them?
Okay, so I have like maybe 4 rules that I go by, that I teach all medical students and residents. So rule number 1, patients cannot have what you don't know. So you got to know your stuff. And to know your stuff, you got to read. Now, it's not easy to know everything. It's difficult, actually. It's like you drink from a hydrant. If you drink from a hydrant, you get very little water. Every time you study, you spend 2 hours reading, you only retain 10 minutes of whatever you read. And then you go to the next level, more hydrants pouring into you. You haven't even absorbed what you just read last year, and now there's more hydrant. So it's important to have strong base. If you have a strong base, you're learning, it's like a pyramid. The more the higher the level, you feel a little more comfortable and feel like it's less work. However, if you don't have that base, you will collapse when you get there. So my advice to all students and residents, rule number 1, patients cannot have what you don't know. It doesn't matter which specialty you go in, because medicine is still medicine. So if you are an internist, if you choose to do, if you don't know how to diagnose diabetes with, a cutoff of, let's say, A1C, or blood sugar level, patient comes in with this particular level, and you're like, oh, you don't have diabetes. But it's you who don't know what the cutoff is. You send the patient home with no medication, they come back and they might die because they have too much, too high blood glucose, right? So if you don't know, they don't have. If you know, they have, and you treat. And the rest is just a matter of patient listen to you, not listen to you, whatever. So in any specialty, same thing with surgery. If they don't know what appendicitis is like or how it presents, why would you operate on the patient, right? You wouldn't think they have appendicitis and therefore they're not going to remove that appendix. So same thing with me. If I can't diagnose what the monitor is telling me the body is doing, I can't give a drug correctly. I have to have a diagnose. I grab a drug. If I grab the wrong drug, patient will be dead. So every job, every specialty has its own thing. Bottom line is, if you don't know, patient don't have. Rule number 2, you need to be efficient in whatever you're doing. My specialty in particular has a lot of procedures in it. So I do procedures day in and day out. I put in an IV, I do a procedure in the back, I put a central line in, I do nerve block where I put the needle right next to the nerve and I put the medication so then they don't have pain. So efficiency is important. You don't want to look like someone who grab this thing, put it down, grab it again, put it down. How many times are you going to grab and put it down? So you need to know what you're going to grab next. What's your next step? So you look like you smooth and you slick from someone who's looking across the street. Rule number 3, which is, another advice that I give to residents and medical students, is to not jeopardize your workspace. Your workspace has to be pristine, clean, and, for us, for example, drugs. I put drugs at the same place every time. So if, quote unquote, shit hits the fan, even if I don't read, I know that's the drug that I want. But obviously, every time even in an emergency, you still look and read what you're giving, right? But if let's say your station is like messy with all garbage and needles and all drugs, you reach your hand over there, maybe a snake will bite you from that pile of stuff. You need to be neat, So other specialties, same thing. Whatever you do, you don't jeopardize your workspace. And then rule number 4, generally, do not trust other people. So let's say for me, for our specialty, if someone said, I set up the room, there's a saline bag hanging already, I set up your, procedure tray, blah, blah, blah. You come in, I toss that IV bag, because how do I know that person didn't inject any drug in that bag to sabotage? I don't know who they're going to sabotage, the patient or me, right? So I'm not going to trust that bag that's already open and spiked and give it to the patient. What if the patient dies on me? That's the license that I work hard for, right? So if, I just go in, I don't trust anyone's work, I just do it myself. Same thing with anesthesia, there are many drawers that we put stuff in. Every morning I check the drawer. It's a job of an anesthesia tech to stock each drawer for me to have the equipment. But if I rely on them every day, what if one day I wanted that particular equipment, I open the drawer during emergency and there's nothing there. Then I'm screwed. The patient will be dead and that's it. So my advice would be get into a habit of, not that you don't trust people, you don't trust people. You just, check yourself, do your work, and you'll be fine. So those are generally my 4 rules that I teach everybody.
Thank you for those. Those are very insightful. You said read a lot. So is there more like new research coming into anesthesiology right now, and how do you keep up with that?
So I have a magazine, I would say, and that sort of sent to my house every month or every week or whatnot. But I'm not really like searching for articles to read every day. Aside from the magazines and articles that come to my house, I just, read my book like an hour a day in the morning to keep up with, maybe I forget something, because after, when you are a med student or a resident, you tend to read more and you remember basic science, which is to me the most important thing. It's the basis of your knowledge. If you know basic science, you can understand pathology of what is going on with the patient and figure out. You're not a robot. You can use that information and use the basic science that you know to figure out what's going on with the patient. But if you're a robot, you can't think critically. You can't apply what you learn and plug it in with the situation that you're facing. So therefore, you can't really figure out. So that's why basic science is important. However, as you are more removed from being a student, being a resident, when you're attending, you just treat work like your job. It becomes a muscle memory. It becomes a routine, right? So obviously you're going to forget. And that's why I like teaching residents, because to teach them, I need to know. So sometimes I forget stuff, I would reread, and that's how I keep up with things that I forget.
Okay. So so how does this job affect your family life and your mental health? Does it come in the way, or is everything pretty much chill?
Once you become an attending, your life is very good.
Okay.
If you have to, aside from you become a doctor because you want to help people, right? Like when you go into medicine, during interview season, they're going to be asking you the very famous question, why do you want to become a doctor? And the classic answer would be, I want to help people. I want to save lives, and I want to do this. I mean, it's the truth. I mean, that's what you do day in and day out. You save lives, you help out people. But everybody who has a career, you have a career because you need to function in a society. You need to pay for stuff, right? You just happen to be a doctor. And doctors just happen to get compensated really well in America, not in the world. In Europe, they don't get paid like that. But in America, we get paid a lot, right? Well, obviously, relative compared to other career minus finance, we get paid relatively a lot. Now, every specialty has their own cutoff, obviously, and unfortunately, the more procedures you do, the more pay you get, right? Because you sort of risk, there's more liability, essentially. Because one thing about America is that we sue people a lot. So the more likely you get sued, the more likely you get paid. So when you become attending, you get paid much more, probably 6 times at least more than what you get paid as a resident. Your life becomes suddenly very comfortable from, living as a resident, paycheck to paycheck, to like this amount of money where you can support the village. You know what I mean? And and some people still live like a resident because they want to save money for whatever. Or some people just live a luxurious life because they want to. So to answer your question, how does this job affect my family? It has, brought more happiness, because I grew up as an immigrant. We were poor when I was young. I worked 3 jobs to, get through college and help my mom, pay for stuff. So now, like, my brother doesn't have to work, my mom doesn't have to work, and I can afford the life that I want to live in. So it has been good.
Well, congratulations. So how would you say, how do residents get paid? Is it procedure by procedure, or is there some other way?
No, so residents usually get paid, it's federal funded. And each program has its own numbers of how many residents they can get, and that's how they get money from the federal government. So the average salary for residents doesn't really matter which specialty you're in, is roughly, depends on the state, obviously, 50 to 60,000. But obviously, if you go to the state where you're like Midwest, when the cost of living is so low, it could be 45,000 as well. But if you're talking about California, like with East and West Coast, where
Yeah.
cost of living is high, the average is about 55 to 60,000.
About 60. Okay. And can you remind me again how many years of residency?
4 years.
4 years.
It depends. So internal medicine is 3, pediatrics is 3. Emergency medicine start to merge into a 3-year program. They used to be traditionally 4. Some programs are now 3, and the rest of subspecialties are all 4. Starting with 4. So ophthalmology 4, anesthesiology 4, dermatology 4. When you get to surgery, that's 5. When you get to neurosurgery, that's 7.
Oh, okay. Yeah.
I think neurosurgery is the longest the training, 7 years. Yeah.
Okay. So does your pay increase as you go through residency, or is it static?
It is increased, but not by a lot. So if first year they start you off 55,000, next year maybe 57,000, and then the following is 59,000. It's not like it's not by month, but it does go up.
And then for anesthesiologists, it's a procedure by procedure you get paid.
So that depends also where you practice. So the majority of practices is salary. There are some practices that you get paid by you eat what you kill. So you can get paid per case or per procedure that you do. But the majority of the jobs that are out there is salaried, meaning everyone does work, and whatever we charge the patient, we pool together and you get income.
Oh, okay. How would you say, what advice would you give to my viewers who are going into medicine and they're about to either start medical school or even college? What final advice would you give on top of the advice you gave to the about the residency?
So I would say you need to be disciplined in whatever you do. Everyone has different life, right? Some people need to work and also support themselves and then study. Some don't need to really do much and just study. But at the end of the day, you need discipline.
Yeah.
If you don't have discipline, you can't get through this thing. We like to think when we look back to, wow, how come the selection process is so tight? It's because and how come at the end of the day we still don't have enough physicians? And really the rigorous training and schooling that we have gone through is to weed out people who cannot take the training. Not that you're not smart enough. Everyone has some sort of intelligence, but how much can you take from this training is another story. So 1, you have to have discipline. 2, you have to have endurance. You can't, go in and be like, oh my God, this is it. Like I'm breaking down. And then, this is it. So the whole process why do you think one of the courses you have to take is physical chemistry? Organic chemistry. Yeah. Which involves a bunch of, molecules and back attack and all that reactions, right? Do I use it now? Never. I never have to know the reaction at all. But why did I make you take that course? It's because they need to weed out the weakest link. So they make you take all these rigorous, difficult courses. So whoever can't take it, you go. And then they put you through rigorous training, not only to weed you out, but also if you cannot do what it takes to become a doctor, you can't treat the patient. Why would you trust that person to treat your family member if they're not competent? You know what I mean? So from the beginning, it's discipline, endurance. Later on, you need to really care about your patient. You need to know your stuff. If you don't, you can kill the patient. So,
Well, thank you, Dr. Clarke, for being here. I hope you guys enjoyed the video and learned a lot. Comment down below what profession you guys want next. And like and subscribe. Thank you.